Welcome to the Healthy You podcast from NorthShore University Health System, where we tackle trending topics in healthcare. In this episode, we'll be examining the opioid epidemic in America, which is responsible for the deaths of tens of thousands every year and has been declared a nationwide public health emergency by the U.S. government.
You act like an animal. Your brain tells you you have to have this drug to survive.
Addiction knows no socioeconomic barriers. There are no boundaries to this disease. It affects any socioeconomic status.
If you just go to Google and type in internet drugs, like the first few links are all how to buy internet drugs.
I'm Andy Buchanan, and in parts 1 and 2 of this series, we heard from a patient who detailed her battle with addiction and from experts at NorthShore's Chapman Center on their work treating individuals struggling with substance use disorders. In this episode, we're talking to Dr. Michael Nelson, a NorthShore physician who is on the front lines of this epidemic, helping save the lives of overdose victims who come into the emergency department and working with patients who need help overcoming their addiction. Dr. Nelson also talks about the history of substance abuse in society and the frightening trends he sees today.
My name is Michael Nelson. I'm an emergency medicine physician initially by primary training, and then I went on and did subspecialties in medical toxicology as well as addiction medicine. So I predominantly work in the emergency department as well as taking call for toxicology overdoses and then seeing patients from the addiction standpoint here at NorthShore.
So when somebody comes in who's overdosed, they call you?
Yes, quite often, or one of our other partners, Dr. Gerald Lycan, or Dr. Michael Wall, as well from the toxicology standpoint for the overdose.
And we did talk a little bit with Dr. Parisi and Patty about Narcan. Is that like
Narcan?
Narcan, sorry. Yeah. Can you talk a little bit about, what is the response when somebody comes in like that?
Yeah, it's quite dramatic and amazing to take a person who's barely breathing, non-responsive from a heroin overdose, and give them a dose of naloxone, which is the generic name for Narcan, and literally within seconds to watch them essentially wake up and a lot of times it's quite like on the movie Pulp Fiction, where Uma Thurman gets injected into the heart with epinephrine and it sits straight up immediately. It's quite dramatic like that, actually, where people will have such a dramatic response and breathe and talk, and even sometimes so dramatically they go into immediate opioid withdrawal right afterwards, depending on the dose. So as the ER doctors, we work at all 4 hospitals in the NorthShore system. And then I also work at John H. Stroger Hospital at Cook County in the city as well, too, doing emergency medicine and toxicology.
Now, in your experience working in those places, what are the trends that you have seen in kind of drug addiction?
It's been quite dramatic for what we're seeing for drug addiction across the board. It's always been there. I think recently, though, it's become more of a public awareness thing in the past year or so with the opioid crisis that's been around. But from my training working in the city and at Stroger Hospital, commonly referred to as Cook County Hospital, drug overdose, heroin, cocaine abuse, it's been there and it hasn't gone away. I think there's just been more awareness of it. In the suburbs, we see quite a bit of it as well, too. It wasn't publicized as much, people didn't talk about it, but it's always been there. I think in the past few years we've seen a dramatic rise in the amount of overdoses that have been coming in, but again, it's been there.
And why do you think that is? Is that from the prescription drugs? Issues can then kind of cascade into heroin use and fentanyl and...
Yeah, so that is a multifactorial and complicated answer. Drug abuse, substance abuse has always been there in human history. You go back to ancient Sumeria, there's carvings on the walls of people drinking like honey pot beer and smoking hookah. The Ottoman Empire tried to outlaw hashish in the 1300s. You go back to opium wars between Britain and China. On painting of the Sistine Chapel, there's a painting by Michelangelo, The Drunkenness of Noah. So throughout all of human history, we've had issues with substances and trying to control human use of substances. So I think when you ask why we have an issue, it goes to the nature of human beings and the way in which people will, for lack of better terms, escapism or for recreational high and euphoria type feelings, potentially trying to escape their daily lives and have that feeling of just enjoyment, because that's what human beings want. And then sometimes that will spiral out of control for some individuals for whatever reason, whether it be genetic, social, psychological issues. But there are some people that are more susceptible from just the occasional recreational use to truly addiction, which will go outside of societal norms and lead to these issues.
So tell me a little bit about addiction medicine and what you do from that angle here at NorthShore.
Yeah, so once a patient is recognized as having a problem with substances, then the next step is always having that patient want help, because despite everyone trying to tell them they need help, until the patient themselves wants to get help, they won't. So once they're recognized and the patient wants help, we're there to try and help them, and we want to help them. So addiction medicine itself is trying to, one, control the substance use disorder from whatever it is, whether it be opioids, alcohol, nicotine, stimulants, hallucinogens, to find the ways to which we control that, whether it be through cognitive behavioral therapy, counseling, or sometimes medication substitution. So that way they can get off their behaviors that will lead to decreased societal norms, interactions, break up families, prevent them from going to work, and restore that balance back to their life, where then they can be a participating member of society, be at home with their families, go to the work, and not spend all their time and money trying to obtain the substance. So the root of addiction medicine is truly restoring the person back to who they are as a person, and not letting that substance use control them in their lives. So there are many, many different avenues, and when we talk about people with, for instance, opioid use disorder, because that is what the national talk is about right now. For instance, it is taking them off their heroin use and then transition medicine called Suboxone, otherwise buprenorphine, naloxone combination. So that way they no longer have the cravings to go out and get these substances off the street, and that they can start developing normal daily patterns and routines in life that don't involve always trying to get high, so to speak.
So we have the Chapman Center here, and does your program have a name?
We don't have a formal name like the Chapman Center. It'd just be a clinic for addiction medicine. So, and it differs from the Chapman Center. The Chapman Center is an amazing and wonderful resource that our hospital system has here. But not everyone needs all the psychosocial support. And not everyone has an underlying psychologic issue or problem that led to the root cause of their substance use issues. Most studies will show somewhere around 40 to 50% of people have underlying psychiatric illness or disease with the co-occurring substance use disorder. But that still leaves a large gap of 50 to 60% of people that don't have those underlying issues. For instance, somebody that may have had pain issues or had a surgery and then got hooked on Norco, potentially from inappropriate prescribing or from ongoing pain. But then from there, it spiraled out of control, where they went to the street to buy the substances, and then they went to heroin or something else to help control their pain issues. And it truly was just a medical cause for why they got, so to speak, addicted to these substances or dependent on these substances. Because there's a difference between dependence and addiction. Dependence means that if you get rid of the substance, people will go into a physical withdrawal, versus addiction means they'll break those societal norms to obtain the substances. So we'll see a lot of people that are dependent on medications, for instance, like a cancer patient that truly needs these to help control their pain. But if you get rid of them, they'll go into withdrawal, versus then that patient that winds up, again, buying these substances illegally.
Maybe you could explain a little more what a typical, maybe not, there's not a typical patient, but somebody who you'll see.
In terms of when we talk about treatment for substance use disorders, there are multiple different levels of treatment, as we'll kind of define by the American Society of Addiction Medicine type criteria. So there's like level 1, which is just purely outpatient treatment, like a clinic setting, like you're going to see your doctor or your primary care provider in the office, which is essentially what my clinic is. It's a little lower level of addiction treatment, but again, that might be appropriate for some people, and a lot of people might want that, versus like a level 2 treatment for addictions, which is kind of more the Chapman Center, where people can go for intense psychosocial counseling, can be there for many hours throughout the day doing group therapy and support, which a lot of people do need that. And sometimes they don't necessarily need some of the psychiatric treatment, they just need the group help and the support from other people that are going through with it, or the counseling of how to deal with some of their behaviors that then wind up leading to their substance use. And then there's what we call like a level 3 type treatment, which would be like a residential treatment, which a lot of people have in their mind because they'll see this on TV or on movies, where they need to go into a drug treatment program where they're separated from their family and separated from life, so to speak, and their job, or if they have a job, for a month, and then like a Betty Ford clinic. And then there's the level 4 treatment, which is in the hospital, intense, like for a person who's very sick, going through bad alcohol withdrawals. A lot of people are familiar with the term DTs for that, or terrible opioid withdrawal where they just can't tolerate being at home from all the vomiting and diarrhea. So it would be like in the hospital or level 4. So when we talk about addiction treatment, there's kind of a spectrum of this. And a lot of people might need to move through that spectrum over time. Some people will need to start at a place like the Chapman Center and get their life a little in order and learn how to cope with things. And then over time, they become more stable and they've been on a dose of medication that has helped them be stable, like again, Suboxone, and they can kind of move down or transition down to an outpatient level of treatment, or they don't need the psychological support or counseling because the substance use was driving their depression, and that once their substance use got under control, so did their depression or their anxiety as well too. So we like to be able to provide that spectrum of care and treatment for patients, rather than just having limited options. But truly, like most things in this world, we work well together rather than being independent and separate. So that's why we've had such a nice close collaboration with the Chapman Center and Dr. Parisi, and being able to talk on the phone anytime we need to talk about a patient that we want to move across the spectrum of care, depending on that patient's needs.
Today's podcast is brought to you by Healthy You, NorthShore's online source for timely health and wellness news, inspiring patient stories, and tips to lead a healthy life. More information can be found at northshore.org/healthy-u.
Now you touched on something that I wanted to explore too, was kind of the stigma of opioids, but they are necessary for some folks.
Absolutely. And they are very potent and very good pain relievers, and they are absolutely appropriate for many individuals, particularly like a post-surgical pain procedure that does need it. But again, it's the balance of finding what's the shortest duration that you need to be on this, rather than, hey, here's 100 pills, this will get you through the next month till your follow-up appointment. That might not necessarily be appropriate from a prescribing standpoint, but like what's the right balance? And that's not an easy answer because it's different from person to person, and everyone's individual pain thresholds are different. So I definitely think that with the opioid crisis becoming public and people having more of this conversation, at least it's increasing awareness, which is something from the medical standpoint, I can tell you, we've been talking about this since the 2000s, early 2000s, of how this was a growing problem, and we've known as a community of providers that this has been a growing problem, and we've been talking about how can we fix this, but until we got public support as well as legislative support and the ability to treat people, it has become a growing problem that it was just kind of spiraling out of control out of everyone's hands. People need their pain medication, especially when they have these acute bad issues like a broken bone or a bad dental pain or a surgery that's needed. And they shouldn't be afraid to take them, but they should be taking them in the shortest duration possible and aware of the risks. And I think sometimes when you educate people, provide the awareness for them, then a lot of people will make their own self-determination about their ability to take some of these medications and their need for taking them. It's what we call the principle of beneficence. And that the individual will generally choose what's best for them, rather than having the old 1960s way of doing medicine of, I'm the doctor and you gotta listen to me and this is it, So it's really a shared decision-making between the patient and the physician about their pain goals, about the expectations, about the risks of the medications, and then maybe alternative ways of managing their pain as well too. Maybe they only need 3 days of Norco And then after that, they can switch to ibuprofen or Tylenol because the pain's only going to be bad for 2 or 3 days, instead of, again, here's 4 weeks of a medication, and that way, there's not extra pills sitting around. The teenager in the house isn't taking these pills recreationally because they see them sitting there, which is another issue. So people need to be aware of this. And so that's one of the really, I think, highlights of the opioid crisis, is that it finally opened up the conversation and started to destigmatize opioid issues or substance abuse issues, because historically people have thought of this as a social problem. Oh, if you really wanted to quit, you just would, And a lot of people think it's a moral fault of these individuals, and that sentiment has been pervasive in medicine for a long period of time as well. So truly, when we got this national crisis that's going on and the president up there talking about this, it's opened up the conversation about why substance use disorder is a medical disease. And I often like to compare, we don't blame the diabetic when their blood sugar spikes. We don't blame the hypertensive patient when their blood pressure spikes up a little bit. We say, well, how can we help? And do we need to tweak your medication or adjust this a little bit? Or was there something that perhaps happened in your daily routine that led to this? And we work together to try and find that answer. And historically, when it came to substance use, it was, well, good luck, you should stop on your own, and see you later, and you're just another addict, all these kind of sentiments which were inappropriate. And now with this dialogue going on, now we're starting to talk about this. Well, this is a disease, and relapse is a part of the disease, and we shouldn't fault patients if they have a relapse. We should say, look, as soon as you do, come back in, let me help you. Let's catch this before it spirals out of control and ruins your family life, gets you fired from your job. And it's okay, because this is a part of your disease, but let's catch it early. Let's talk about the ways we can work through this and why you relapsed, or how we can help you prevent future relapses. So that's really been the beautiful thing over this past year, is just kind of opening up people's eyes to the medical aspects of this problem.
Jumping back just a little bit about the recovery process, can you just walk us through a little bit when somebody comes in and says, I had this surgery a couple months ago, and I there was a lot of pain, and I've been on this medication, and I'm now dependent. Help me.
So first is obviously getting to know the patient as an individual, and then finding out what their individual goals are. Is it truly pain control that they want? Is it being off these medications altogether? What their time frame is for getting off these medications? What they expect out of it as well too. Getting to know if there are underlying psychiatric reasons that potentially drove them to use substances or not. And so it's getting to know the patient, and then also letting the patient getting to know me, because like anything in this world, it's a relationship, so to speak. And it only works if both people are invested in that relationship and both people have trust. So the patient has to trust in me as well too, and want to work with me, because if we're not a right fit, it's just not going to work. There's no standard protocol that works. And the protocolization of medicine will sometimes then lead to a lot of people not fitting into that protocol, and then they get left by the wayside. So we truly have to individualize and tailor our medical therapy for that patient. But if you had to generalize a little bit, let's take opioid use disorder again, because again, that's the hot topic right now, and say, well, hey, I'm on Norco because that's one of the most commonly prescribed opioid painkillers out there, and I've noticed my dose has escalated significantly. And because of this, I started buying some from the street because my doctor said, this is all I'm gonna get, but it wasn't enough to control my pain. And now I feel like my pain's under control, but I've noticed my life has spiraled out of control because I'm spending a couple $100s a month on these painkillers from the street. And I've recognized this as a problem, and now I want help from you. So then I'll say, okay, let's take that issue and let's make sure that there's nothing else driving this as well too. How's things going at home? How are things going? Do you feel mentally fine? Are you feeling depressed over this? Are you feeling anxious about it? Like, what else is behind all this? And talk through those things first. And then say, okay, well, we can transition you off all of these pills and kind of put you on essentially one a day and get you off all these prescription medications like Norco or Dilaudid or oxycodone. And so then a lot of times we'll take that person and switch them to Suboxone as well too, which the whole point of that is it's a little longer acting drug. It doesn't quite activate the opioid receptor as potently as your full opioid agonists do. So a lot of people won't quite get the same euphoria that is associated with it with the other full opioid agonists. And then from there we can taper that down, and it's easier to get people off that and taper them down rather than going into like full opioid withdrawal from the other medications. With Suboxone though, we do have to have people in opioid withdrawal for a very short time period, so you have to have people stop using their medication for about a day, and then they come in mild withdrawal, mild to moderate withdrawal, and then you'll induce them on Suboxone, and then from there, now we have a little bit more control over their medication use. And then based on the individual, it might be like, look, I need a month or two to get my life in order and sort some things out, get my job stable, or I just don't feel it's the right time to taper off all these. For the heroin addict, it might be like, hey, I've been using heroin for 20 years and I need to be on this medication for years sometimes, because I know as soon as I stop, I go back to using my medications. Versus other people say, look, I want to be off all these altogether, and we'll do more of a rapid taper over the course of just a couple of weeks to get them off medication. And then it can fluctuate, where some people are like, look, I've been good for a month or two and now I'm ready. And it can change at any minute or time. But it does give us a little bit better control over their physical dependence on the medications, and it's easier to kind of taper it off rather than dealing with some of the full opioid agonists.
Today's episode is brought to you by the Doreen E. Chapman Center of NorthShore University Health System, which offers comprehensive treatment for individuals struggling with substance use disorders. For additional information, please call 847-570-4633, or to schedule a first appointment, please call the Access Center at 847-570-2500, option 2.
So you have, I guess, an interesting perspective working at Cook County and then also up in the northern suburbs. Mm-hmm. But, Dr. Parisi and Patty got into a lot that addiction doesn't know any kind of socioeconomic or demographic boundaries, right? Is that what you see as well?
That is absolutely correct. It affects all spectrums of our society. And again, I think that goes back to, I alluded to earlier, the base of human nature, as well as development of the brain, the dopamine reward pathways in the brain, the prefrontal cortex, which kind of puts the brakes on that and is the inhibitory aspect that says, that little voice in your head says, this probably isn't a good idea. Versus, again, those dopamine, like, yep, I'm going to jump out of the airplane for this rush and euphoria that you get from it. And it's a balance between that. And so it goes to the very root of human nature, the evolution of human beings, where you had to take risks, go out hunting and gathering, so to speak, to where we see as a society, and we don't quite think about that. But I think that's why we don't see societal boundaries when it comes to this, is because it's who we are as human beings. And yes, absolutely, my perspective is that. And I get to work with poor, underserved patients in the inner city to more affluent patients out here in the northern suburbs, which is, again, one of the more affluent communities in the Chicagoland area. And it affects everyone. And sometimes the substance use patterns might be different. In the inner city, we see a lot of the classic drugs, so to speak, like heroin, cocaine, marijuana, versus some of the suburbs, we'll see prescription opioids, synthetic marijuana, but you'll absolutely see a lot of heroin as well too, and it has made quite a bit to the suburbs. And then even the composition of heroin's changed, where over 90+% of it is mixed with fentanyl, which historically has been thought of as what we'll use in medicine as a very potent analgesic for surgical pain, or need it for, again, like a long bone fracture type pain control, but it's kind of permeated throughout even the communities in the heroin. So, and then even think about like alcohol use disorder, it's everywhere. Almost roughly 8 to 9% of the American public has alcohol use disorder. So it affects everyone.
And I understand there's also now something called like research chemicals that kids and people can order off the internet. And what is that all about?
The internet is a wonderful and amazing thing, but also a dangerous thing at the same time. If you just go to Google and type in internet drugs, like the first few links are all how to buy. internet drugs. So people can buy base chemicals, create in kind of in their own home labs, and make their own substances. Actually, in 1991, there was a book published by Alexander T. Shulgin titled Phycol, which stands for Phenylethylamines I Know and Love, and essentially how to create a lot of these stimulant-type medications that are kind of like MDMA or ecstasy or kind of like uppers, and how to just make them on your own. So like everyone's seen the TV show Breaking Bad, or quite a few people have. It's a great television show, or if you haven't seen it, but there's like a little allusion to how you could buy pseudoephedrine and then make MDMA, and that's why a lot of times that'll be Sudafed is now behind the counter. You can't just buy it over the counter anymore. So the internet provides a lot of great information out there for people when they use it appropriately, but there's a lot of other information of how people can use for illicit purposes as well. So there's precursor drugs that people can buy, and then they can synthesize some of these chemicals in their own home and then sell them. A lot of people tried to do this to skirt the law. So if people kind of remember back around 2011, 2012, there was an outbreak of bath salts and synthetic cannabinoids because these were sold at gas stations or head shops where they didn't need a prescription to it, and they would buy these substances to use to get high.
Would your message be for people who are kind of really caught up in the midst of addiction?
Definitely that there's help out there. A lot of people feel that no one wants to help them, that they're down in the dumps, that they're all on their own. If they ask for help, there's help. The hardest part is taking that first step and asking for help, admitting that they have a problem, and then seeking that help out. Once they do, though, they'll be surprised that there's a lot of help out there. And sometimes there's barriers and there's hoops they have to jump through, and it's not easy. Nothing in this world that is worthwhile is easy. Everything takes work. And yeah, a lot of people have to take that first step. But once they do, there's going to be people there willing to help and wanting to help. So I would definitely say ask for it. Seek it out. People are out there wanting to help during this problem and during this crisis, and we want to get people better. And as everyone in the healthcare industry went into this job wanting to help people, everyone. No one went into it saying, oh, I just want the glamour and lifestyle because it looks great on television. We went into this job to help people and ask for help, and we're there to give it to you.
How has it been for you in your career? Is it a rewarding career, or is it depressing at times? Or I mean, you're dealing with some very heavy issues and intense situations. And how is it for you personally?
Oh, it's all of that. It's every spectrum of emotion. I have a unique perspective because of working in emergency departments, toxicology with the Illinois Poison Control Center, and addiction medicine. I went up seeing the spectrum of care. I see the patient when they overdose. I see them when they die from their overdose, and the family members that are left in the wake, the children, the parents, the brothers, sisters, the spouses. And it's heartbreaking, and it is depressing at times when you see that, and you take that home with you a lot of times, and you have to internalize it and deal with yourself. A lot of people don't think about the healthcare workers, though, that I almost liken this to micro forms of PTSD, so to speak, for the healthcare providers. And we talk about from the physician standpoint, there's a lot of burnout in medicine, and there's a lot of factors into that. But emergency medicine has some of the highest burnout rates in all of medicine, and I think a lot of it's due to just those daily negative interactions, so to speak, of just life stressors and life traumas that happen, and then physicians take that home with them and have to deal with it, or they have to pronounce somebody dead and then walk into the next room with a smile on their face and say, how can I help you? Like nothing happened. And it is difficult from those standpoints at times. And then it's very personally rewarding from the addiction standpoint when you can say, hey, I had this problem and we got off the medications, and then it winds up restoring families and lives, and you see people just happy that they're back together again. And so it's a full spectrum of emotion as a provider and perspectives of it. Like, again, you get the intellectual reward, you get the rewarding standpoint when somebody does get through it, and then the heartbreak too when people relapse or have the overdose, and it's everything.
Can you talk about that point a little bit? Because it's not like someone is cured, correct? I mean, this is a lifelong battle.
Absolutely. It absolutely is. People will go 30 years after their last use, and it'll still always be there in the back of their head. And that's why, for instance, a lot of people can understand alcoholism because, again, the high prevalence of it. A lot of people have family members with it, but a lot of times, they'll say once an alcoholic, always an alcoholic. That you can't even have one drink because it's sometimes that one that then will spiral out of control for the individual. So yes, once they have an addiction, it's always there and it's always there with them. But as time goes on, they learn to deal with it, and it does get better for most people. But it can only take one little thing, one stressor, sometimes that might break them and send them back to their substance use.
What drew you to this particular field?
Yeah. Well, first off, I'm a nerd. I love chemistry. I got a master's in biochemistry. I knew I always wanted to do medicine and help people, but I really liked the chemical interactions in the body and physiology. And then from there, doing emergency medicine, I wound up seeing a lot of people with these issues filter in. So I went ahead and did toxicology because of my love of chemistry and physiology. And then I wound up seeing the way in which trends of which human beings use a lot of substances, and always kind of asked why and how can we help? And then that kind of led to addiction medicine. Personally, there are also, again, everyone's kind of touched by this, there are also family members that have had substance use issues. And I don't think there's any family throughout the country that hasn't had something, at least in maybe not the primary family, but extended family members that have had some degree of this. So there's always that kind of personal reward from my own internal interests, just what keeps me motivated to doing the job, and what I find fascinating about the job, and then the way in which I want to try and help people and use that knowledge for the greater good.
Do you feel like the media is doing a good job in covering this?
Well, my perspective of the media is always, well, they're going to take whatever the hot topic is because that's what sells. But the more stories that are out there, then all of a sudden we start having a true conversation about what there is and how we can get to working. So with the opioid crisis, we've started to have all of these great conversations with it, which is the beautiful part about it. And we start getting to the real world truth. Just starting to talk about substance use disorder in general is the appropriate steps that we need. And I'm more than happy to take the opioid crisis as a launching pad to then start talking about all the other issues that people wind up having and how we can get to the root cause of helping people long term, because that's our goal, is to help everyone, or at least inform everyone about the decisions that they're making. And like anything, I can't force people to make choices for themselves, but I think it's our duty as healthcare providers to educate people about their choices. And then again, under the principle of beneficence, people should be allowed to choose what they think's best for them, just like anything. And if they choose that they want to use substances or smoke or whatever it is, at least they're informed about their choices beforehand, as well as the consequences of their choices.
I'd like to thank Dr. Michael Nelson for joining us today to share his experience in responding to the opioid epidemic. I'd also like to thank Patricia Estreen and Dr. Laura Parisi for talking to us about their work at NorthShore's Chapman Center. And special thanks to Sharon for sharing her personal journey of addiction. I hope you found this series on the opioid crisis both informative and entertaining. I'm Andy Buchanan, and this has been the Healthy You podcast from NorthShore University Health System. Thank you for listening.